This episode of The Curbsiders is brought to you in partnership with NephMadness and the American Journal of Kidney Diseases, AJKD. And I guess that means, and this is our final episode, so I guess that means Hannah's back with her final pun.
Oh, I can see the thrill on Paul's face. Yes, absolutely. So I'm here with a final pun from Dr. Michelle Rowe, who will need no introduction to our NephJC audience, but she introduces herself on the track. So here we go.
Row it out.
My name is Michelle Rowe, and I'm a pediatric nephrologist at the University of Minnesota who does clinical research in glomerular and genetic kidney disease in children. I also thoroughly enjoy being on the board of directors for NephJC, a Twitter-based nephrology journal club that you all should participate in. How do nephrologists know if their research is going well? Low p-values.
Are we talking about urine?
We should probably just start the episode.
Oh, you should just leave that long stretch of silence in. That is perfect.
Podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of those and should not be interpreted to reflect the official policy or position of any entity aside from possibly Cash Like Moore Hospital and affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Hey, Stuart, we're back.
Hi!
I saw you were under your desk for a second there.
I was chasing my cat.
The audience can't see you, but I'm sure they'll be glad to know that you're chasing a cat around your office as we're supposed to be recording an intro.
Or so you claim.
Well, I heard her scratching down there. I'm afraid she actually used the restroom in here.
Oh boy! All right, we got to finish this up so we can all get off air, get to sleep. It's very late at night, and Dr. Paul Williams is going to tell us what we do on this show. This is an episode from NephMadness. We're talking about pain management, but Paul, in general, what do we do on this show?
In general, I don't even know anymore, man. We are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. We also get to know our guests up front. I mean, listen, you like books, don't you? Everyone likes books. If you don't like books, I'm not sure I want you listening, if I'm being honest to you. So sure, go ahead and skip ahead if you hate books. Otherwise, just stick with this. Learn about some books. Get some smarts. That's it.
That's so well said. I always look forward. I'm just like, I don't know what it's going to come out as. Is it going to be angry? Are you going to give the audience a pass? Tonight, you told them that if they don't like books, then they can go to hell, basically.
Yeah, basically.
But on this episode, Stuart really likes that one.
I gotta mute it.
Okay, Stuart muted himself because he's in a fit of laughter. On this episode, we have three wonderful guests, and we're talking all about pain medication, pain management in chronic kidney disease. We're talking about a couple classes of pharmacologic agents, opioids, tramadol, which we put in its own class, NSAIDs, and GABAergic meds like gabapentin and pregabalin. We talk about some of the pitfalls of these medications and how you should think about them in CKD. There's a lot of great clinical pearls in here from our guests. Our first guest is Dr. Samantha Gelfand. She is a second-year nephrology fellow at the University of Pennsylvania and the primary author of this year's NephMadness Region on Pain Medication. She was a resident and chief resident at Yale New Haven Hospital and will soon go on to live it up as a PGY-7, who needs the money, in hospice and palliative. This is I should mention, she wrote this bio. So she says she was a resident and chief resident at Yale New Haven Hospital and will soon go on to live it up as a PGY-7, who needs the money, in hospice and palliative medicine fellowship at MGH/Dana-Farber program in Boston starting in July. She is planning to practice palliative nephrology, also known as renal supportive care, which is focused on alleviating the suffering of people with kidney disease. She is fluent in French and Spanish, forgivable in Italian, and in a prior life, she was an editor-in-chief of Let's Go Travel Guides. Our next guest, Dr. Matthew Sparks is the co-creator of NephMadness. He is a physician scientist at Duke University. He is the Associate Program Director for the Nephrology Fellowship and Director of Medical Student Research in the Department of Medicine. His lab is interested in understanding blood pressure control and hypertension pathogenesis by the kidney. He serves on the AJKD Social Media Advisory Board at AJKD Blog and as faculty lead for Renal Fellow Network. He is on the board of NephJC and a key faculty member of the Nephrology Social Media Collective internship. He serves as education director for the annual KidneyCon conference. Follow him on Twitter at NephroSparks. Our final guest, Dr. David Gerlink, he isn't quite sure how he got involved with this whole thing. He's an internist and clinical pharmacologist / toxicologist at Sunnybrook Health Sciences Center with an RE in Toronto, Canada, North Dakota, and head of the Division of Clinical Pharmacology at the University of Toronto. He's also a medical toxicologist at the Ontario Poison Centre. He divides his time between patient care, teaching, and using big databases to study the safety of prescription drugs in clinical practice. We are thrilled to share these three wonderful guests with you and this great topic from NephMadness.
You know, Matt, if I was a nephrologist, I would name my kids Andrew James and Caitlin, so I could say my kids are AJ and Katie.
Very quick disclaimer before we start the show. Dr. Gerlink tells a anecdote from his past when Stuart asked him about a favorite failure. It is probably, I would say, like PG-13, so feel free to skip ahead if you have young kids in the car, but I think it's relatively harmless and mostly innuendo. All right, enjoy the show. Thank you to all three of you for coming on the show. So we're going to start with Sam. And Sam, I wanted to ask you, can you give the audience a one-liner about yourself and include something outside the world of medicine?
Sure. I love one-liners. Okay. I'd say I am a 32-year-old former travel guide editor who changed paths to medicine after suffering a temporary delusion that people would be more fun to edit than books.
That's pretty good.
It's interesting.
Sit outside of medicine.
Yeah. Travel guide. I imagine you got to travel a lot then?
So I edited the guides, but we worked as a group with researcher writers who were traveling and sending back copy.
Okay.
It was back in the snail mail days where they had to actually send home paper in a package, and they wouldn't get paid until the package arrived. It was incredible.
All right. Matt, did you want to give the audience a one-liner?
Okay. I'm Matt Sparks. I was a music major in college. I played the trumpet. My goal was to be a principal trumpet player of a symphony. And I quickly realized that the real reason I was there was to be a high school band director, and decided that I did not want to do that.
Okay. I'm totally lost.
Presumably because you loved music and hated to hear it tortured.
Well, I love to play music, and I necessarily didn't want to make the arrangements on the football field, the round sort of. You've been to a football game, you've seen it, and someone has to design that.
Yeah.
That's the band director.
I was in marching band for all 4 years.
Okay, then you know what I'm talking about.
Absolutely.
So you went from being a trumpet major to pre-med, and now
it was a really easy thing, and this is how I like to describe it, is that I was in the College of Arts and Sciences at the University of Arkansas. And if you pull open the course guide, it wasn't online back then, it was just a book. And you would pull up music. And then right before that was a section on microbiology. And I just was very fascinated with the courses in microbiology. So I switched my major to microbiology and was going to do research. And I decided that, hey, you could go to medical school, be a physician and research. And I said, that's even better. Yeah. So it's a very logical progression.
So you basically plan your life out in an alphabetical order in some way.
Exactly. Yep, that's exactly what happened.
Dave, how about a one-liner from you?
So I'm a PGY 25 internist and do a bit of a side hustle in clinical pharmacology and toxicology. I'll take I was going to say something different, but I'll take a page from Matt's playbook there. So I almost went into music for a career too. In fact, in grade 10, I almost failed grade 10 actually, and I was sort of dead set on playing drums in going to a jazz program in rural Nova Scotia. But I think in the nick of time, I just sort of realized that I wasn't good enough to be a professional drummer. And as it turns out, I was in a band, and the bass player's sister was like 5 years older than me or 6 years older, and she was a pharmacist, and I had a crush on her, and I thought so I got talking to her, and I heard of pharmacy, so I ended up applying to pharmacy and got into that first, and from there the interest in medicine developed. So I didn't say it was a good story. But.
Paul, why don't you ask a question and before we move on?
Probably about a book.
Yeah, why don't we, as an oldie but a goodie, why don't I start with Sam and ask, just recommend any book at all, and it can be that physicians should read. It doesn't have to be medical. It can be fiction, nonfiction, shoot the moon, but just what's a good book we should be reading?
Well, it's a oldie, but I think it's a goodie. Is A Movable Feast. You guys read this one? It's by Hemingway. It's a classic. It's kind of an easy read, a pleasant read, but it's full of small vignettes from when he was living in Paris and all of the sort of artsy, writerly sort of company that he kept. And it's super escapist and very, very pleasant read. So that's my pick.
Excellent. Solid recommendation.
What's your, kind of along the lines of the favorite failure, if you can recall your first patient complaint, what did you learn from that, and how did that change your practice? I'm going to throw that to either one of you.
So what was the question again? My first patient complaint?
And what you learned from that, if you can recall it.
Well, this is going to come across as a weird one. I mentioned that I was a pharmacist before I went into medicine, and so my first patient complaint was as a pharmacy student. And I want you to picture that it's like in the late 80s, and it's my first sort of real proper summer job, and I'm in this dispensary. This was back in the days when the people in the dispensary would actually answer the phone. And I pick up the phone, and this voice asked if we had a product called Two in the Butt. And I sort of said, what? And it was a woman. She asked again, and I thought it was a prank. And I sort of said, well, I got a bit testy with her, and I got a bit irritated. So like an hour later, this little old lady kind of traipses down the aisle with this box, and the box is a hair coloring product called Second Debut. But she was pronouncing it Two in the Butt, and so she complained to the manager that I hadn't been very polite to her. We just cracked up after she left because of how she pronounced it. Anyway, what I learned from that is I hadn't thought of the story now, but Two in the Butt is an excellent way of pronouncing that product, and sometimes your first impressions are wrong.
Wow.
Sorry. You asked.
Okay, Matt.
I like it.
I don't have to say anything.
This has been another episode of the Curly Riders.
Matt, I'm going to give you this dealer's choice. You can give us a book, you can give us a favorite failure, a patient complaint, or just career advice, whatever you want.
For me right now, it's going to be just something that I'm using right now that's helping me out a lot. And I'll say that I found this from Twitter. I was asking people, I was very frustrated with EndNote, just driving me nuts. Mm-hmm. Someone would send me a paper, and then it would, sometimes the same thing would be cited 3 or 4 times for random reasons. And so I found Zotero. Have you all used this?
No.
Yeah.
So there's a nice plugin for Google Doc. Works well across different computers. You sign on, you can just go to PubMed, hit a button. You have a plug-in to your browser, Moxella, or whatever you use. And it's really made my life a lot easier. However, I have not actually shared this document with anyone else yet, so it might not work on the receiving end. But for me personally, it's working out fairly nice.
It's a good segue from Two in the Butt.
Try to, but they first told me the name was Zotero, so it's like, okay.
There's your Two in the Butt.
Oh, I get it.
There it is. That's it.
Second
No, that's an old-
2ND.
Wait, what was that again? It went away.
Usually Stuart will look up the product that we're talking about, tell us how many copies are left on Amazon, and
I was looking for
how
$2
much it's currently selling for. How much is that currently selling for, Stuart? Can I get that on Amazon?
I don't know. I couldn't even find that. I found the movable feast, but anyways.
All right, Paul, why don't you save us, and let's start with the clinical case here.
Sure, that sounds great. Let's talk. All right, deep centering breath. Let's talk about Mr. Thomas Payne. He's a 62-year-old gentleman. He has a history of high blood pressure, diabetes, and chronic kidney disease. His most recent creatinine gave an estimated GFR of 17, and he has a history of significant microalbuminuria, categorizing him as CKD 4A3. He is being seen in the clinic because he is complaining of significant knee pain, which is from his known osteoarthritis. A knee brace and physical therapy were not helpful. Previous knee injections have helped with pain, but only for a short time. He asks, Doc, these painful times are trying my soul. What can be done for my pain?
So NSAIDs, right?
Well, I think we wanted to make the proviso before we sort of get deep into this episode that we understand that pain management is complex. We understand it's not just medications, but what we're talking about here is primarily safety of medications in patients with chronic kidney disease. I think that's going to be the focus of much of our discussion. So before we get too deep into the weeds, we just want to point out that we realize there are other modalities and other things to talk about in terms of pain management, but we're talking specifically about certain classes of medications. So to start, what are the major pain management modalities in patients with chronic kidney disease?
So it's a great question and an important sort of framework to put out there, because I hope we get to talk about all of them. We all know it, like you said just now, pain management's complex. We're just going to focus on the meds. And I think, when you boil it down, if you just boil down every conversation you've ever had on rounds or in clinic, you can start to feel like there's no good option. Like NSAIDs are evil, and Tylenol hardly works, and opioids are dangerous, and all the rest of them that get a lot of, FaceTime in the press or that are other options, like Tramadol, gabapentin, antidepressants. Those are messy and hard to manage. So, as a nephrologist, I think you can end up feeling exasperated or at the very worst nihilistic. But all of those modalities have benefits and they have potential risks. And depending on the individual patient in front of you, I think any one of them could be useful.
And what we're hoping to highlight with this show and get from this discussion with you all is what types of pain are we going to face in our patients that have CKD, and what are the common classes of medications we might think of using, and what sort of pitfalls do we have to look out for so we can safely use these medications. And so the ones I guess we're going to highlight tonight are opioids. You mentioned gabapentin, tramadol. We'll talk about what exactly that is, and then we'll talk about, of course, NSAIDs. So, Sam, why don't you start with opioids? What are some big things we need to know? And then I want Dave and Matt to chime in with their 2 cents as well.
Yeah, absolutely. So, opioids. When you're thinking about prescribing an opioid for a pain syndrome in the context of kidney disease, I think the most important things is to ask yourself are. First of all, does the pain syndrome, is it likely to respond to an opioid? And secondly, sort of the pharmacology of the opioid you're going to choose. So that boils down to 2 different aspects. Number 1, what are the metabolites of that opioid? And number 2 is, are the metabolites cleared by the kidney and are they metabolically active? So this gets back to some stuff I think we learn in med school when you first start learning pharmacology, but somehow doesn't enter into conversation as frequently as it should on rounds, at least not unless a pharmacist is with us, right? But when I think about it, I do think that some people we grow familiar with or sort of more comfortable with certain opioids because we see them titrated, we see them used often, and those can actually be the sort of least favorable choices for people with kidney disease because of their metabolites. So specifically, the opioids that we commonly see used, like morphine, codeine, oxycodone, morphine and codeine specifically, those metabolites are cleared by the kidney and they're metabolically active. So if you give it to someone with kidney disease, those metabolites are going to build up and they're going to continue to exert an effect while they're built up in someone's system, which results in toxicity versus some of the other opioid options like hydromorphone, for example, Dilaudid. That one is clearly one of the least preferred agents of pretty much any house staff or fellow or nephrologist that I work with in general. But actually in the setting of kidney disease, I think the metabolite, which is H6G, does build up, but it's completely metabolically inert. So it will eventually be cleared either by the kidney or by dialysis. And in the meantime, it doesn't cause a toxicity syndrome.
Dave, do you have anything to add to that about the opioids? Like, how do you break them down that way? You have morphine, and then you have they're the synthetic ones. Is that hydromorphone and oxy?
Yeah. So the naturally occurring ones are going to be things that come from the poppy directly, like codeine and a bit of morphine, and everything else is semi-synthetic or fully synthetic in the case of something like fentanyl or tramadol. I guess, I sort of reflecting on this a little bit, and Sam touched on this a few minutes ago, and she raised an important point. Then let me frame it this way. So if I said to my residents or anyone who's listening to this podcast, you had a patient with pain, and you're trying to pick a pain medicine for him or her, what are you trying to do? And usually the residents or med students will say, we're trying to relieve the pain. And of course, that's true. And if you push them a little bit more, you say, well, but what are you really trying to do? And they'll say, well, I'm trying to improve function and improve quality of life. And I think that's how we tend to think. But I think that's a little bit, and not to get too philosophical about it, but I think that's a little bit, we tend to focusing on the benefits and and Sam mentioned earlier, sort of the trade-off, sort of the benefits versus the harms of the drug. And I think I would put it this way. Every time you approach a patient with pain and you're going to start a new medication, what you're trying to do is afford the patient more benefits than harms. It's sort of an obvious thing to say, but it actually bears stating because with a lot of the agents that we might use, the harms are kind of hard to, like the benefits are relatively easy to sort of pin down, but the harms are sometimes occult. And I can, not to ramble too much, I can come back to that in a second. But so when you're treating pain, what you're doing is conducting a little experiment on the patient, and you don't know at the outset what the result of that experiment is going to be. But what you're trying to do is afford the patient more benefits, pain relief, improved function, quality of life, and so on, than harms. And the thing that the issue I have with opioids, and I've changed my thinking on this quite a lot over the last 15 years, is that the harms with chronic use, especially, can kind of begin to masquerade as benefit. And if I was to single out one harm, it would be this issue of dependence. And so you've all seen this happen, right? The person, you try some acetaminophen, doesn't work. You're scared of NSAIDs, so you go right to opioids. And after certainly a couple of days, or even certainly a few weeks on opioids, people become physically dependent. And that's important because if you cut back the dose, or they go without the dose, they feel miserable, right? They have pain, they've got, insomnia, they've got all of the sort of features that someone with opioid withdrawal, a heroin user might have. And they feel better when they resume the drug. And they totally understandably infer that this drug is helping them. And so the drug that might have in the first couple of days of therapy really been relieving their pain and making them feel better is now, the primary benefit, especially as the dose goes up, is the avoidance of withdrawal. And so I don't mean to belabor that point, but I think it's something we don't talk about nearly enough. And I think, I'm not saying that we don't have a role for opioids in chronic pain, but if we think about that kind of paradigm a little bit more, I think we should maybe be a little more critical of the drugs and try and interpret the anecdotes of the patients we got in light of the pharmacology of the drugs that lurks in the background. Sorry for the long-winded answer.
Matt, do you use opioid pain meds in any of your patients on dialysis or just with advanced kidney disease? And is there any one that you think is more preferable?
Well, I can honestly say that I have not used opioids for probably 5, 6 years. And I think this case in particular really highlights, this is someone with the EGFR of 17 and very late stage kidney disease. And you also have another situation where the prescription of an opioid could really alter, sort of how you're going to examine the patient or see them. And, when they start having symptoms of kidney failure and potentially needing kidney replacement therapy, it's going to color sort of how the patient's feeling. So this is a really tricky situation. I'll say this is a very unusual scenario when someone comes to you and is not already on many of the other drugs that we are in this NephMadness region, gabapentinoids and others, and really highlights the high risk scenario that they're under. And there's a lot of research that's happening now to show that patients that are on dialysis, and I would probably lump someone who has an EGFR of 17 as pretty much being there, have higher rates of falls and altered mental status. They're on muscle relaxants as well, which have their own problems. But I do think it's important, and outside of this case, and we've talked a lot about ensuring that you talk about the negative aspects of opioids, but it is still important for individuals to know which ones to avoid. And we see this all the time. And this happens, and I've been on a real big kick to stop baclofen. They say, well, what should we take? And I'm like, well, I'm not really advocating anything. I'm just telling you what you shouldn't do. And so this, you talk about morphine, meperidine, codeine. These are no-nos, like never. And so I think that's what we want to highlight those, because they do have these toxic metabolites that are more powerful than from whence they came. And that's really a scary thing. And they also are very protein bound. They're hard to remove by dialysis. So they'll stick in the system for a long time. And they can really pose a very difficult problem when, for instance, we've seen patients in the hospital who get morphine.
Yeah. It's kind of scary though, because the opioids that are recommended we don't have a lot of experience with. At least most internists don't, like methadone, buprenorphine, fentanyl, hydromorphone. When you think about someone leaving on oral hydromorphone, that just kind of makes you feel a little queasy.
In Canada, I mean, we see it all the time. It's probably our number one opioid here.
Wow.
Yeah. I might just Matt's comment about never morphine. That you mean that for chronic pain, right?
I'm talking about a patient on dialysis.
Fair enough. Okay.
Talking about someone with a really reduced EGFR. You just have to watch out.
And I'll say, I am currently a nephrology fellow, and avoid NSAIDs, avoid nephrotoxins. These are not helpful statements to anyone in notes. Do not give is also, something I try to avoid as a blanket statement in my notes. Because take this patient, you were from Kashlak with the GFR of 17, and say instead of chronic knee pain, he was coming in with an acute pain. You're facing a hard decision there, where for that person, an NSAID may actually be that straw that breaks the camel's back in terms of tipping him over into an AKI that ends up resulting in a requirement for dialysis. So it might avoid starting an opioid, which everybody wants to champion, and it's clearly a good idea epidemiologically. But for the individual patient, I just think it's very complex to say do not give, as a blanket statement. You're going to always be weighing the risk benefit and the chronicity of how long you're going to be using it. And it's a pretty individualized judgment call.
I will say that us adding baclofen to our notes has really helped a lot in people not giving it to patients that are on dialysis, for instance.
I wonder if it's because that sticks out, because it's not, I think because it's not well known, it might just jump out at people that, hey, don't use this baclofen. Oh, wait, why shouldn't I use that? And then they realize that it's renally cleared.
But I think I think the NSAID one is a good one we'll get to later. And I completely agree with, there is some scenarios in which it can be helpful. So just a blanket statement can be dangerous, but there are other, but I think that there's a conversation that can occur. And I've been really thinking about this, and how do we educate people about these things? and they're not getting it in the books, the lectures. It's happening. So that's why we started button campaigns, wearing buttons in the hospital to bring awareness to some of these medications that are dangerous in patients on kidney disease. And I'm thinking about, what are ways in which we can get our message out about what drugs should be, and maybe not avoid, but use it cautiously, or maybe, hey, you should ask me about this medication that has a lot of problems in patients with kidney failure. And I just don't think that it's on the radar of the general internist. And I get all the time, wow, I never knew that. I never knew baclofen was cleared by the kidney.
Right.
And I never knew, and so that it's very important to get that message out there.
So I just want to respond to one other thing you said, Stuart, which was, the options that are safest, quote unquote, safest in CKD, like hydromorphone and methadone and buprenorphine. I think it's a complex social historical thing that methadone and buprenorphine are as siloed as they are in the U.S. And I just recently I did this amazing month-long rotation in Sydney, where I was learning about palliative care in nephrology. And one of their sort of safest titratable opioid options for pain in people with kidney disease is actually a Norspan patch, which is buprenorphine. I don't know, Dave, if that's available in Canada, but I think it's too bad that we don't have it as an option in this country.
You do have a patch in the U.S. I forget the name of it, but it's approved by the FDA for chronic pain.
It's Butrans.
So buprenorphine, Butrans is the same as here.
But you still need an X waiver to prescribe it, right?
So the U.S., no offense, guys, but the U.S. is weird on the whole buprenorphine thing. Like
Oh
it
my
is,
gosh.
Totally.
the idea that you can come out of medical school and your first day with an MD, you can write a prescription for fentanyl patches, but you need some special training to write a prescription for bupe is crazy.
It's insane.
And people die because of it. People die because of that. I mean, it's very difficult to justify. Buprenorphine is, it's a special drug. I have seen, not just for patients with addiction, but for pain. I've seen people, I use it a fair bit to transition people, CKD or not, off of high doses of opioids, people who are on 200, 300, 400 milligrams of morphine a day. And, done properly, their pain very often improves dramatically and their quality of life improves. It's an incredibly versatile and quite safe drug compared to full agonists.
Our producer Justin is sending us just to clarify, in the U.S., I'm pretty sure that you can prescribe buprenorphine for pain without an X waiver.
Yes.
The X waiver is for addiction treatment.
Addiction, that's right.
Exactly.
Dave, I wanted to ask you about the WHO ladder, specifically for chronic pain management in CKD 4 and 5. It lists step 1 is acetaminophen, step 2, use with caution, tramadol, and step 3 is for severe pain. They prefer hydromorphone, fentanyl, methadone, buprenorphine. That's where Stuart was getting that from. And they say you would cautiously use oxycodone, and as Matt's pointed out multiple times, morphine, meperidine, propoxyphene, codeine, those ones are, should not use in CKD. Can you comment on if you are using any opioids in patients with chronic pain and CKD, and how do you approach that? Well,
I think it's important. The whole issue of opioids for chronic pain, you'll get very different questions when you ask different clinicians, and people have very divergent views on the role of opioids for chronic pain. I don't prescribe them very often, and when I do, it is with a lot more caution than I did 15 or 20 years ago. Like I thought nothing 20 years ago. I had a patient with sickle cell crisis and they were on high doses of opioids, and they came in pain crises. I'd bump their pain meds up, and I didn't think about it. I had this simplistic, and I think a lot of us still have this sort of kind of simplistic, it's full agonist, and if the patient still got pain, you just need more of it, as if it's that simple. And it's way more complicated than that because all of the side effects are dose dependent. And when you get to doses, like I was referring to a while ago, it's very easy to harm the patient more than help them. But back to your question, the ladder is not nearly creative enough. And I think I have Like I think there's this. We start with acetaminophen, then we go to NSAIDs, then we go to opioids, and we throw in gabapentin or antidepressants just because we're trying to find the right sort of concoction for a given patient. I don't know how, it's probably very state dependent in the U.S., but I think we might want to give a little more consideration to cannabinoids, not inhaled. I'm not saying a person should roll a joint and smoke it necessarily, but oral cannabinoids. I mean, there's a good example of a drug. It might not help, but it's probably not going to hurt. At least it's not got no side effects, but it doesn't have the same pharmacological baggage as NSAIDs and opioids. So if I'm looking at this case here and thinking, if I had some 60-year-old guy with bad CKD and I was kind of reluctant to use NSAIDs and I didn't want to commit him to chronic opioid therapy, and I don't think a whole lot honestly about some of the other drugs we'll talk about. If that guy says to me, listen, I can at bedtime take a puff off a vaporizer, or I can take a small dose of some CBD oil or low THC oil and it doesn't interfere with my function too much and my pain is better, I think that's a win. So I think that the idea that this ladder exists, and by the way, the original WHO pain ladder that was just bastardized for decades was introduced in 1986, and it was meant for cancer pain. And we just took it and just extrapolated it to chronic pain based upon nothing. Like no data at all. But there are so many other things we might consider. And I think it's easy to be a little too enthusiastic about cannabinoids, but I think they're a consideration.
What about ketamine for chronic pain for dialysis patients?
Well, I'm a huge fan of ketamine in the hospital. I mean, I think it's a very versatile, extremely safe drug, 0.1, 0.2 mg per kilo IV over 15 minutes. It's hard to hurt somebody. You give it too quickly, you space them out for a little while, and that's about it. As an oral agent for chronic pain, I don't think it's a good idea. It's hard to get, but even if you could find someone who did respond to it, it's got some serious bladder issues that we don't. I mean, you occasionally will see people who get chronic, nasty, irritative bladder and sometimes even upper GU symptoms from ketamine. So to me, it's a versatile opioid sparing drug in the acute care setting. I don't think it's got a huge role to play in chronic pain.
Well, I find it kind of curious that we're ignoring, I feel like, an obvious choice, the completely non-addictive, as good as opioids, reliable, particularly dosed tramadol. I mean, it's right there.
It's safe.
Yes. I totally walked past you asked the question about tramadol, and you put it in the ladder, and I just talked around it.
You did.
So, do you want me to talk about tramadol? Should I just unleash that?
Yes.
There's nothing we would love more.
It's what we want.
Okay.
Game for it.
So just to make a point. So if anybody, I wrote a blog post about this on Talks in the Hound a couple months ago. And I should make clear that I think there are some people that tramadol can help. And you will find people who are on low doses of tramadol, and it seems to be achieving the goal we talked about, benefits exceeding harms. But tramadol is a funny drug. So tramadol itself, this is a synthetic opioid made in the 60s. It is an SNRI. It's more or less like venlafaxine, and it interferes with the reuptake of serotonin, norepinephrine, and it interferes with pain pathways through that mechanism in the dorsal horn. It's metabolized, though, to an opioid, a pretty good mu agonist. Goes by a couple names, but M1 is the sort of the common name of it. So we tramadol enters our armamentarium with this. It's advertised as having two mechanisms of action. It's got a bit of an SNRI. It's got a bit of an opioid. Doesn't that sound great? And it's also perceived as a mild opioid. And in a lot of countries, and including until recently in Canada, it wasn't treated as a controlled substance. It was in Canada for years. It was in the same, classification as atorvastatin or hydrochlorothiazide. You needed a prescription, but it wasn't. A lot of docs and dentists had the perception that it was somehow devoid of all the opioid-related harms, despite the fact that its metabolite is an opioid. The problem I've got with tramadol isn't just that kind of messiness. It's the fact that the conversion of the SNRI parent compound tramadol to its metabolite is accomplished by an enzyme in the liver, the same enzyme that turns codeine into morphine, CYP2D6. And we have wildly varying levels of that enzyme. Some of us have none. We won't make any opioid. Some of us have several copies of the gene that encodes for 2D6 and will turn tramadol into M1 like nobody's business. So, the idea when you start somebody in tramadol, in that little experiment I mentioned a while ago, where you're trying to help more than harm, you're introducing this variability, this like you don't know whether you're giving somebody mostly venlafaxine or a lot of morphine equivalent. Like you don't know. And I think it's not that it's wrong to ever use it, but I think it doesn't make a whole lot of sense.
As you're saying this about this, I think probably if everyone thinks back clinically to patients they've seen and talked to about tramadol, you get some of these patients to say tramadol doesn't work, and then you get maybe a small subset of patients that are like, I love tramadol, it works well for me, I feel okay on it, and those are the only patients that I'm really using it for. Of course, we've all read this Toxin Hound post, which I have to say is legitimately, I mean, other than Sam's NephMadness post that she wrote, this is one of my favorite pieces of medical writing. I mean, it's just you mentioned that I think this is you're talking about that the active metabolite is ODT, which is a mu opioid agonist, and you say ODT should not be confused with founding member of Wu-Tang Clan ODB, Old Dirty Bastard, who collapsed and died in 2004 with cocaine, and I kid you not, tramadol in his system. I thought that was finding a way to put ODB into a blog post about tramadol and make your point. Just really,
I can die now. It's,
your career if you retired.
What will be in your system?
ODB.
So I think that the point you're making is, what I'm hearing is that patients that take tramadol, we don't know if they're going to get just the SNRI effect, or if they're going to get a little bit of the mu opioid agonism, or if they're going to get a lot of it really quickly. And then can you talk a little bit about the kind of the variation you said in the Middle East or some other places, maybe it's more likely to be abused?
Right. So that enzyme, that CYP2D6 enzyme that turns codeine on, like codeine, for example, doesn't have any analgesic effects until it's turned into morphine. Tramadol is converted to M1. That enzyme varies, like most genetic things. It tends to travel in sort of respects ethnogeographic sort of areas of the planet. If you're in the Horn of Africa, so Ethiopia, Somalia, probably a third of people, or in Saudi, the Arabian Peninsula, probably a third of people are ultra rapid metabolizers. They'll convert tramadol to M1 very efficiently. If you go north, the farther you go from the equator, the less likely you are to be an ultra rapid 2D6. And in fact, if you go to Scandinavia, it's pretty common for people to have no functional 2D6. And if you give them codeine, my limited experience with people from Finland is they don't want analgesia anyway. But if you did give somebody from Finland codeine, it's not going to do anything to them. And tramadol might have some SSRI or SNRI kind of effects, but not so much of an opioid effect in that group. You could, in theory, genotype somebody, but I think that's just unnecessary. It just complicates matters. And even if you did genotype somebody, if you genotype me and found that I had ultra rapid 2D6, and I should, in theory, turn tramadol into its metabolite, I might be on bupropion, or I might be on paroxetine, or something else that turns off 2D6. And this is another issue, by the way, if you happen to have someone on tramadol and they're doing okay, and then you deploy some 2D6 inhibiting drug like bupropion or paroxetine would be the biggies, or amiodarone, you could precipitate opioid withdrawal. So one of the other concerns I've got with tramadol is its interactions. So.
Yeah, and on that note, everything we're saying about tramadol applies to anyone taking tramadol. In the context of people with kidney disease, the interactions is just something we have to think about carefully, since the average patient on dialysis is on something like 19 medicines. So I think we're just, that's true no matter what
19.
When you're on that many. Yeah.
And some of the other concerns, because I think we should move on to NSAIDs and the GABAergic drugs. So this kind of the first part, we're essentially Matt Sparks was sending us a message. We haven't mentioned that these are the categories in NephMadness, right? So there's opioids versus NSAIDs. So we're about to talk about NSAIDs next, and we kind of jumped the gun. We talked about tramadol ahead of time, but tramadol is going against what, Matt?
It's going up against gabapentinoids.
Okay, so that's
sort of lump them all together. And I just want to talk about this really quick, and that people always ask, like, well, how do you pick a winner, and why would one win over the other? And I think that one of the things about NephMadness is, like, how long a team stays alive in the tournament is more time we get to educate people about whatever the topic may be. So it's not necessarily saying that one is better than the other for pain meds. It's that now we have another platform to talk about one of them and not the other. And so that's how we sort of see it now. That the Blue Ribbon panel is a panel of esteemed nephrologists throughout the world, and they pick the winners. And so we don't really know if they think like I think or what, how Joel thinks, but that's sort of how we sort of envision this would be. And just like on a test, when you miss a question on a test, you tend to that's when you finally learn it.
Well, you'll be excited to know that our producer Justin Burke picked normal saline to go all the way. So if that would be,
we'll see about that. Well, there's our 9 nephrologists that are we have a love-hate relationship with normal saline. We're not even going to go there on this podcast at all.
Yeah.
We talk about it in other ones.
Yeah, we spent on this. By the time this airs, the Fluid Wars one will have aired. Okay, so tramadol. Some other things to point out: look out for seizures, possibly serotonin syndrome if you combine it with a bunch of other drugs, and hypoglycemia as well. But you can read the post on Toxin the Hound we'll listen to. You can read Sam's write-up for NephMadness as well if you want more on that. And now, why don't we go, Sam? So back to this case, our guy with knee pain here. Why not give him an NSAID? What's the downside? You mentioned already his GFR is kind of on the last legs here, his EGFR.
Yeah. So, right. Contrary to what will have you believe that NSAIDs are evil no matter what, I think the data over the last 30 years of studying it is a bit mixed on whether long-term NSAIDs have a direct effect on increasing incidence or progression of CKD. It's different from this situation where this person is living on the verge of where we start to see symptoms and metabolic consequences of renal failure, which is a GFR, usually around 15, although it varies from person to person. So, why avoid an NSAID in this person? Well, how do NSAIDs work? They inhibit prostaglandins and thereby inhibiting prostaglandin-mediated inflammation, which we perceive as painful. So that's a good thing in general when you have a toothache or a inflamed, I don't know what, but
knee.
Knee. Well, no, but
gout flare.
Yeah, gout flare. The problem with inhibiting prostaglandins in certain people with kidney disease is that renal blood flow in some people is prostaglandin dependent. So there are some specific conditions that worry us most, and mostly conditions of reduced effective arterial blood volume, like heart failure, cirrhosis with portal hypertension, and sometimes nephrotic syndrome. In those people, the systemic physiology is such that the renal blood flow is dependent on the prostaglandin. So you give an NSAID and you will see the GFR go down because you will see less filtering. I mean, less blood is really getting to the filter, and therefore creatinine goes up and everybody gets worried. I think, even if you don't have one of those 3 conditions, when you are this close to the border of stage 5 CKD and needing to make decisions about dialysis, you're running a risk there that even a transient reduction in blood flow from, say, 3 days of NSAIDs, you might or might not rebound from that when you stop the NSAID. So this particular situation is a bit risky. On the other hand, things I think we don't appreciate is that, for example, an anuric person, someone on dialysis, all of those effects that we're talking about, the reduction of renal blood flow, as well as some of the more sort of electrolyte-related effects of sodium retention, hypertension, all of those are out the window if you're anuric. And so I think, if this person were already on dialysis and he's having a flare of his chronic knee pain, a short course of NSAIDs is a reasonable option, knowing that, of course, AKI is not the only risk of NSAIDs. You have to be on the lookout for GI toxicity, bleeding, other aspects of it. But it's a good example of how the individual case really helps you make the judgment call of how safe or worthwhile the risk the medicine's going to be.
Dave, you have any comments on NSAIDs and CKD or just in general?
Yeah, I think, so general comment, I think, we've all been burned by NSAIDs in one way or another, right? So GI bleeds or AKI or heart failure or what have you. I do think that over the last couple of decades, we've been inculcated with this idea that opioids are safer than NSAIDs. The pendulum's starting to swing a little bit, but especially in older people, there's this perception that you wouldn't touch an old person with NSAIDs, but opioids are okay. I think I've sort of staked out my thoughts on that a little while ago. In this guy, I sort of agree with Sam. I'm kind of worried about his afferent arterial. I'm worried about making his GFR 17 drop, and I guess he's also diabetic. Is he on? I don't know if he's on ACE or not, but there's also the risk of hyperkalemia here, and having diabetes is going to be an independent risk factor for that. So I don't know. I'd be pretty reluctant. Much as I generally favor NSAIDs over opioids, I'd be kind of reluctant in this fellow, given how precarious he sounds.
Matt, I'm going to ask you the tough question. Actually, I know Stuart's probably going to ask this one if I don't. Stuart, the topical NSAIDs?
Absolutely. I wanted to ask that specifically.
Okay, so that's mine. Okay, I think that I mean, from what I've seen about topical NSAIDs, not a lot will be absorbed, and that could actually be an option for this individual. But one of the things I wanted to highlight outside of what we've already talked about is that chronic NSAID use can also lead to hypertension, and you will see in patients that you'll take care of, wow, stop the NSAID and your blood pressure comes down. And there's a variety of mechanisms that of why this occurs, and we're trying to understand that and try to minimize that effect. So hypertension is something that this is a little outside the context of necessarily CKD, but that effect is even worse in a patient with CKD.
Does the site of location affect the absorption at all, or the renal adverse events? Like, let's say I have some lower back pain, but it's actually costovertebral angle tenderness, and I'm putting it right over my kidney.
You just want to, yeah. So if you actually place the patch on the kidney, is that what you're trying to do? Let's not do that.
Dave, do you know much up in Canada? Are topical NSAIDs used much? Do you know much about have much experience using them in patients with CKD? Does it give you pause?
Well, I mean, they certainly get diclofenac in particular gets a fair bit of use. I got to say, I don't usually get too concerned about it. Maybe I haven't thought about this enough, but I would have no problem. Again, if the goal is the experiment and if it has a chance of helping the patient, I think the harms have got to be lower than systemic ones. So I wouldn't. I'd keep an eye on someone's creatinine, but I wouldn't be reluctant to try a topical NSAID.
So the only patient that I've had an adverse event that I know of from using topical diclofenac was a patient that I prescribed 2 tubes of it, and it described that he was only supposed to use it for his hand pain, but the script said apply as directed over painful areas. So he goes home, he takes the 2 tubes, and he takes a shower he basically rubs all over his body. Comes back, his creatinine went from a 1.2 to 5.7 in a 2-day period.
So has this changed your...
Covered his whole body with it.
He covered his whole body in it.
So now when you prescribe it, do you specifically talk about that?
Yeah. Well, I did then as well, but the script got changed after I put it in, so I don't know.
Yeah. I'm assuming that patient didn't have co-pays for his medication. He was not worried about using it all in one application.
He could just get brushing his teeth with it too.
Yeah.
In my research lab, we one of our goals is to try to understand how the different prostanoid receptors cause hypertension. So we have cell-specific deletion of the EP4 receptor. The prostaglandin binds to one of 4 different GPCRs, EP1, 2, 3, and 4. Each one has different actions or on different cell lineages, and The one that we're particularly interested in is the EP4 receptor, which does have a lot of expression in the kidney. And so this is a really fascinating area, which I think maybe we'll have our own podcast about if anyone's interested in listening to it. But I do think that you would be the kidney has a lot of different ways it utilizes this entire arachidonic acid cascade, and I think that's where, as nephrologists, we say it's complex. It's not just the afferent arteriole; it's receptors in the tubules. It's immune cells. It's in the podocytes. It's all over, and I think that's where and just as we talked about with tramadol and all these other drugs, is that they do affect biologic function.
Well, if you want to start a kidney podcast, you're in the right place.
Dun, dun, dun.
All right. I'm going to ignore that comment. And I wanted to make 2 points before we moved on. Sam, you were mentioning patients should be, if they're anuric, so that means we should ask patients on dialysis if they are still making urine, because if they are, then we probably shouldn't be so cavalier with the NSAIDs. That's what I'm getting from what you were mentioning there.
Totes. And
Okay.
actually knowing whether your dialysis patient makes urine at all is helpful for more than just NSAIDs. It changes their prognosis. It changes how you should think about IV contrast. It's a good thing to ask on any sort of history.
So the last thing I wanted to say about NSAIDs, we did a show with Joel. Matt has, in pre-recording, Matt claimed your job as the chief of nephrology at Kashlak Memorial. I'll let you guys fight that out there. But so our former chief of nephrology, Joel Toff, Joel, please don't come after me on Twitter. He did an episode with us on CKD, and we talked a lot about medications, and he has a whole presentation he gives about all the evidence for patients with less severe CKD and the use of NSAIDs. So you can go to that podcast. I think it's like number 64 or 66, something like that. We talked about that. So we'll put that in the show notes for you. But we're talking about patients with more severe advanced kidney disease in this part here. But maybe his point was that for patients with less severe disease, you might think about using them, but you got to be careful with what else they're on. So, Paul, did you want to get us into the next part of the case?
Sure, nothing I would love more. So, unfortunately, Mr. Payne reports that in addition to his knee pain, he's having pins and needle pain in his toes and feet, and this has really been bothering him. It's decreased his ability to perform his daily activities. It's been hampering his independence. Are there other medications that could help with this type of neuropathic pain? And so I think this is our oh-so-smooth segue into the GABAergic medications like gabapentin and pregabalin for pain and how effective and safe they are in CKD.
Yeah. So sounds like this patient who has diabetes has peripheral symmetric distal neuropathy that is probably diabetic neuropathy. And that's so common in people with CKD and people without. So the last section is about, these GABAergics, which, gabapentinoids, GABAergics. I think we've made up both of those words. But it's essentially the class of meds that has been synthesized to be an analog, basically, of the neurotransmitter GABA, which diminishes pain transmission through, the central nervous system and basically a reduction of the glutamate mediated pathway of pain signaling. I think when you're considering one of these meds, a lot of feelings and experiences come up. There's both the experience of giving it to someone and watching them turn into a zombie with altered mental status and myoclonus and all sorts of odd behaviors. And then there's the opposite end of the spectrum where you give it to someone and they lose some faith in you because they say it didn't work at all. And, what can you do for real for my pain? More optimistically, I've come around to find a sweet spot for these meds and a real role for them, as long as they're given with expectation management and with a really careful eye on dosing related to kidney function, as well as other meds and the overall sort of function and illness state of the person.
I do want to get comments from everybody on this. My first experience with a gabapentinoid I guess, adverse reaction, I could say, was as an intern at Kashlak, a woman got admitted with altered mental status, totally somnolent, wasn't intubated, but was to the point where we were doing lumbar punctures and everything. Finally, 24 hours into the admission, her nephrologist calls, got a hold of us, found out she was there somehow, and he said, "Hey, listen, I know what's wrong with her. She always takes too much. She's supposed to take it only once every 2 days, her gabapentin, but she was taking too much. And all we did was just watch her. We had already done the LP and things, and she got better with zero treatment at all. It was just all gabapentin. When she woke up and finally a family member came out of the woodwork, we found out she had just been taking tons of her gabapentin. So it was a good lesson to learn early in my intern year, where I was just like have always been very like, that's the kind of thing you don't forget seeing. Because this woman, she was so sick seemingly, and it was all just this medication.
I think that's what we, as nephrologists, we see this all the time, and we say, it's the medicine, it's the medicine, it's the medicine. And like you said, even though they were prescribed a certain amount, does not necessarily mean that's how much they were taking. Mm-hmm. But I agree with Sam on this point, though. These can be useful in the right scenario. Neuropathic pain is one of those, especially in diabetes, that I have had some success. But meticulous control, meticulously looking at their GFR and dosing the medication appropriately. And that's not maxing it. I always like to go below what the dosing, sort of guidelines say in that, and then also really educate them that this is not something that you want to misuse and just take a whole lot of it. And another thing to tell them is that you shouldn't drive after taking it. You can become altered, or and there's a lot of caveats to these. And I think that's why pain management is very challenging, because it can spend a lot of time talking to them about pain, how to do it right, what you need to think about, and so it's a serious thing that you need to consider when you're wanting to put someone on a GABAergic medication with decreased kidney function. And that's why, when someone's kidney function is getting around the 15-20 range, we're seeing them a lot as a nephrologist, and in concert with their primary care physician, because things are rapidly evolving, and that's where you have to make these dose adjustments on a visit once a month or once a week.
Dave, are you using gabapentin, pregabalin in patients with CKD, and do you have any words of wisdom for the audience?
Yeah, so I think these drugs get used a lot, and I think they aren't as effective as I think there's this perception that they're useful opioid sparing agents, and that we can use them to sort of avoid opioids or minimize the dose of opioids that we use, and I guess because of the GABA sort of. They are GABA analogs structurally, although they don't actually do much at GABA receptors. There's this perception that maybe they're sort of preferred therapy for neuropathic pain. I won't say that they don't work. I mean, you can find some people in whom they will help, but the data on the drugs is really pretty abysmal when you look at it. And I think that and they also they're prone to misuse. They've got a well-described withdrawal syndrome. So I will sometimes use them, but again, I'm just going through that whole exercise of trying to roll the dice and see if I can help the patient feel better. But I've got very little in the way of expectations. If they help, great. If they don't, I would have a low threshold to try and abandon them after a week or two. Mm-hmm. But they are very popular here.
So generally with all these meds, the whole start low, go slow thing. When you're coming down off the drugs, is it a similar thing? For GABAergic, for the gabapentin and pregabalin, you also come down slowly on them?
Yeah, it's probably less of an issue in patients with CKD, because the drugs will hang around and they'll coast sort of, just the kinetics will be such that they'll coast off a little more gradually anyway. But if you had someone who was on 1,800 gabapentin a day, we see this not infrequently, and they were to go without. I mean, they can get a pretty impressive withdrawal syndrome. It looks no small amount like alcohol withdrawal, and it's pretty impressive.
Yeah,
Yikes! And just to compare numbers, when we're talking about starting gabapentin or pregabalin for someone with advanced CKD, the numbers I usually have in mind are, gabapentin of 100 milligrams, on dialysis days only, not 3 times a day, slowly up titrating to effect, but sometimes, toxicity is too great. And for pregabalin, we're talking 25 milligrams a day, not your, standard starting dose of 75. So it's really, I think, important to stress those recommendations as starting doses, because you'll never use the drug again if you give a high dose and they have a terrible zombie episode.
I think I would just make sure that people have, and I think maybe Sam said this, minimizing expectations. I mean, great if they really afford an improvement in pain and function, but I'll go and let me say I wouldn't expect them to do that. I think that they can sometimes help, but more often than not, I just sort of disappointing.
I wanted to make a point, though, that a lot of times as a nephrologist, when we're seeing patients, it's very, very rarely that I ever start these meds. And most of the time it's ratcheting back to stopping. So it's an important thing, though, to look at the patient and look at their med list, to reconcile those medications, see what they're on, ensure the dosing is correct, and be proactive in this approach. We spend a lot of time talking about indications for starting, but we haven't really focused a lot of time on ensuring that we are actively decreasing the dose when their EGFR starts to drop.
We've talked about this on prior shows, but can you Matt, can you tell us, what do you use to estimate the GFR? Are you doing a creatinine clearance with Cockcroft-Gault? How do you recommend the audience tackle that?
Well, there's multiple ways that you can estimate someone's glomerular filtration rate, which is how we measure kidney function. The FDA, when they're approving drugs or what have you, talking about dosing, unfortunately still use Cockcroft-Gault, which is a historical sort of thing. But, at the hospital, we do not use that. We use usually the CKD epi or the MDRD equation, which is it's a little bit more accurate than the Cockcroft-Gault, which was first published in 1976 in an obscure journal called Nephron, which no longer exists. But I think in the end, both the CKD epi and the MDRD equation will give you similar results that you can sort of look at that number and then make a determination for what sort of their kidney function is. And so it's not always like this is the exact EGFR this patient has, because as you can measure it each day and it will change just a bit. But it's sort of, you need to understand, is this very severe kidney function decline? So for instance, the patient has EGFR of 17. And as Sam mentioned several times, that this is where we start to see symptoms down to the 15, 10 range. And so that's pretty poor kidney function. And then you look at the other, say 30, still very, very depressed kidney function, and 60, that sort of gets you to see a nephrologist. So that, just sort of understand that when you look at EGFR, it helps us sort of look at what's happening, and it takes their creatinine and it uses their weight and ethnicity and all these factors and puts out a number, and that helps us sort of gauge what their kidney function is.
Matt, just a follow-up question. If somebody has acute kidney injury, what do you set the EGFR at? You just assume it's less than 30? Is that when you're dosing meds?
Very good question. And this is when someone comes in with AKI, acute kidney injury, this is a dynamic situation. And I usually, you assume they have an EGFR of 0, depending on if it's very severe. But I think you just should assume that you're going to basically have no clearance of anything. And the reason for that is maybe it went from 1 to 2 today, but what will it be tomorrow? And so that, the creatinine elevation only occurs well after the fact of the injury. So you're not really, you actually probably should have done the dose adjustment on your medications the day prior, but we don't really know there hopefully in the future we'll have better markers for acute kidney injury, but currently in clinical practice, creatinine is all we have. Sam, do you want to comment on that as well? You're right in the throes of being a clinical fellow.
Yeah, I mean, what you said, I agree. Not all AKIs are created equal. 0.3 increase of creatinine is probably, doesn't need to dose adjust. But if your GFR is 0, your creatinine will double every day, and so there's a lag. So I agree with everything you said.
Yeah, I was sort of like, nephrologists, we see the worst of the worst, and oftentimes the small elevations in creatinine we're not really called about, but oftentimes there's subclinical AKI that's happening that, and we're starting to try to understand that too. Like, what does that mean? What's the significance of that? And but in the end, I think being fairly aggressive and dose adjusting medications. There's a great trial that was done in a pediatric hospital that was very proactive about dose adjusting medications and really looking at these changes in eGFR. And they found that it really affected outcomes in their hospital. I'll pull up the link and send that, but we covered it on NephJC a few years back.
Okay. So let's get into some closing comments here on pain, and then we can give our picks for NephMadness. So Sam, for this patient, based on what we've told you so far, so this was a guy who has both this knee pain, he has CKD4 on his way to CKD5, he's 62, and he's now and he's got neuropathic pain. What might a regimen look like for him? We've kind of already alluded to it, out of the agents we've talked about. So are you going to use NSAIDs, Tramadol, the GABAergics, the opioids? What might you do?
So it's tough. I think separating out his different pains. For the neuropathy, that one's the easiest one. I would try a low-dose gabapentin, so starting at 100 milligrams at night. For the knee pain flare from arthritis, I think a topical NSAID would be worth trying, like Voltaren or diclofenac. And if that wasn't cutting it, I probably would go for a short course of low-dose oral hydromorphone, 1 to 2 milligrams orally every 6 hours for 2 to 3 days with close follow-up. Okay.
Dave, how about you for a patient like this? He's got both MSK pain and symmetric polyneuropathy.
So I would probably try an oral cannabinoid, but it wasn't one of the options on the list. But I would use it because while I don't know the outcome of this little experiment in my patient, I'd be stacking the deck in his favor by using something that's just inherently less harmful. I might go with a short-acting opioid. Like I wouldn't go with Tramadol because I don't know exactly what I'm getting when I give it. I might try either some buprenorphine or an intermittent and very intermittent dose of immediate release. I hate to say it, hydromorphone at a low dose would be something to consider. I would be wary of giving him a long-acting agent, and I'd want him to use it very sparingly. But honestly, my druthers would probably be with the cannabinoid.
Matt?
Well, I think in this scenario here, and I think that it would, as you can hear in our voices, we're challenged to really definitively say one, because we just talked about all the dangers of all of these. I think in this scenario, I would have to agree that a very short course of opioids would be reasonable, but I would really hammer the fact that we need to follow this patient up very closely. So this would be someone I might even see in a week and say, if I were to start them on an agent, how are things going? Make sure there's a plan in place for really definitively taking care of this knee pain. If they need to see an orthopedic surgeon, if they have, intra-articular injection might be useful in this scenario. And I would really push a lot of other options that are available to help with this scenario. But I think, when it's a patient that's sort of you're not actually in the room and like looking at them eye to eye, it's a scenario like this. I think it is a challenge to sort of say like, I will give X, Y, or Z.
Yeah.
But it's a challenge. I think that's why we wanted to highlight this, and especially a challenge for someone with diminished kidney function. And we wanted to have this and highlight this in NephMadness because I will have, just to be honest, I do think that we do not cover this as much as we should in training programs around the country, around the world, probably.
Paul or Stuart, any other remarks before we get into the picks?
Yeah, I just had one question. So there was a lot of negative talk about gabapentinoids. So I just want to know what you guys think about the show Yo Gabba Gabba. Are you fans of that one or not?
All right, Stuart. Thank you for that. Paul?
Gotta go.
That's a cue right there, I think.
Okay. So
Dave, we need to know what your pick is in the pain region of NephMadness 2019.
I mean, this guy is working on a single nephron, so it's kind of hard to go with NSAIDs. I have to go with opioids in this guy, but cautiously prescribed.
It's not necessarily we have to do it in this guy. We're talking about the tournament. That's okay, though.
Yeah.
Opioids wins for Dave. And then a second one.
GABAergics versus Tramadol.
Gabapentinoids versus Tramadol. Well, that's just easy. I'd go with the low dose pregabalin.
Okay.
I'd set Tramadol on fire.
And then who would you pick for the overall win out of these four classes of pain meds?
So I would go with a cannabinoid, but it's not an option here. So I'd go with a low dose opioid, intermittent, immediate release, very sparing and time limited, ideally.
All right, Sam, I think it's up to you now. As the writer of the region, this is going to carry a lot of weight.
Yeah. Well, I will have a disclaimer that I loved writing this for NephMadness. I still don't quite understand what NephMadness is and the prolonged sports analogy. And
I'll tell you that
I want to understand.
The sports analogy has long since sailed. This is since our seventh year of doing NephMadness, and as I described earlier, here's what we want you to do: is think about which of these topics needs more attention, more discussion. It's more important to patient care. Yeah.
So between NSAIDs and opioids, both extremely important to patient care. I'm glad we're talking about it. I think the NSAID category might teach people more because I think they've gotten a bad rap, and I think there's a really special role for them in kidney disease. So I would go with that one in that bracket. And between gabapentinoids and tramadol, this one's kind of an easy one for me. I think gabapentin and its brothers are a really effective tool when used, carefully. My bigger soapbox is that patients with kidney disease suffer from so many symptoms, not just pain, but pruritus and neuropathy and restless legs. And gabapentin actually has some effectiveness for a lot of those symptoms. So that's in the write-up. I hope that the awareness about that increases, and that's why it's my pick. I'd say it's actually my pick for the whole region.
All right, nice. Okay, so do I need to give mine? I've never actually done this in 7 years.
Yeah, we definitely want your pick.
Okay, but I'll do it. And thank you. So opioids versus NSAIDs, and I'm gonna have to go with NSAIDs. Mainly because I study them. I think it's a really quite intricate system for how the body responds to a lot of stimuli. And as the pendulum swings away from opioids, I think we need to rethink about how we think about this class of drugs. And so I agree that it's time to give them a little bit more discussion than just the flat avoid. And then in the other category of gabapentinoids versus tramadol, sorry, I'm going to go with gabapentinoids. And it's probably the only class of drugs that I have seen, at least it's hard to know, like in a one-on-one patient. That's the hard part. It's like the patients say they feel better from what you're giving them. But it also has the little side addition of baclofen, which I like to give that more attention. So that's why I think gabapentinoids wins that out for those two reasons. And the overall winner of the pain region that's going to be exactly like Sam. I'm going with gabapentinoids. So I think that's going to win our region.
I'm going to agree with our esteemed guest. I think NSAIDs will take opioids. I feel like the pendulum swung away, and like the NSAIDs and anuric patients is a neat thing that I don't think about much. I'm gonna be a contrarian because you people love talking about tramadol. So even though none of us would use it and all of us would favor the GABAergics, I'm gonna bet that tramadol is gonna hang around because people like discussing it. Yeah, and even more contrarian, I'm going NSAIDs for overall. I think NSAIDs for the region.
Wow. So you think 9 nephrologists are going to choose NSAIDs?
100%. I've never been wrong. That's why I win every year.
Stuart?
I'm going to go NSAIDs as well. And I think tramadol as well. Only because I think it needs more press. It needs more bad press. As far as which one's going to win, probably neither. It's probably going to be cannabinoids.
The dark horse?
Yeah.
Topical capsaicin.
Overtime. Oh, yeah.
Okay.
Maybe ketamine.
I think I would choose NSAIDs as well and tramadol, and I would choose tramadol for the win. I think tramadol is I mean from my perspective, I see that one just thrown away. Like I still think there's way too few people that have read the Toxin Hound post on tramadol, and that way too few people who understand how that medicine actually works. So I'd like to see that one. I'd like to see that one done more. Justin, did you want to do your pick?
Sure. Quickly, I would say between opioids and NSAIDs, I would choose opioids just so people can talk about buprenorphine more. I think nice. Buprenorphine is the real winner. In GABAergics versus tramadol, I am also going to go with GABAergics because I'm going to go with tramadol. In GABAergics versus tramadol, I'm going to go with tramadol because I thought the CYP2D6 thing was fascinating and super cool, and that was great. So then in the final between buprenorphine and CYP2D6, I would go with buprenorphine and opiates. But normal saline for the win. Normal saline.
Great. Now you see that, you know, it's a funny little game and everyone doesn't understand it. But look, we all know a lot about pain management and CKD now. So,
yeah,
you know, I think it's an effective tool for teaching, and the fun continues not after, you know, when on April 1st, funny enough, it's April Fool's Day, but that is when the first round is announced.
So we'll see who is right. Who's right?
Really, we're all winners, but I would like a hat. So.
Wait, is it about what we want or about who's going to win? Those are different.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
Yummy.
Get show notes at thecurbsiders.com/podcast and sign up for our mailing list at thecurbsiders.com/knowledge food to get our weekly show notes in your inbox.
That's right, Paul. We're committed to providing you with high-value practice-changing knowledge, and to do that, we need your feedback. So please subscribe, rate, and review the show on iTunes, or contact us at thecurbsiders@gmail.com. A special thanks to our producer for this episode, Justin Burke, and to our social media team, Hannah R. Abrams on Twitter, Beth Garbs-Carpatelli on Instagram, and Chris the Chew Man Chew on Facebook. Until next time, I'm Stuart Kent Brigham.
I'm Dr. Matthew Frank Watto.
And I remain Dr. Paul Nelson Williams, and goodbye.